All right, Kate, you have the floor.
Great. Good morning and or afternoon, everyone, depending on where you're located today. Thanks for joining us again. Today is our August PRQC learning session, and we'll be talking a lot about implementation planning today as we move forward. So as we usually do, we start with our acknowledgement slide. So Crystal, if you can go to the next slide. As you all are aware, the EIIC is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And, of course, the content and or conclusions that we present here are those of the authors and should not be construed as any official position or policy statement of the U.S. government. So at this point, we'll just go into a brief roll call, and obviously there are so many teams and individuals that we have on this call today, and we can't really ask every single person to chime in, but I will just go through the names of the teams. We'd love to welcome the Last Frontier Kids from Alaska, Team 1, the Lifesavers, Mocan Rocks, the Longhorn Kids, North Texas Division of HCA, the Fighter Flight Response Team, the New England EMSC Team, 8 is Enough, RETI for Kids, Ready for Kids, Pit Crew, the REMOC Minions, Whisper, Wrangler for Kids, the Oregon Pediatric Readiness Program, ETCH, and last but not least, of course, the Pediatric Peaches. So welcome all of you. We're glad to have you on the call today. If you did register for this, we will have your names and know, exactly who was on the call so that we can make sure you are able to get that CE credit and the like when you register. We'd also like to welcome any subject matter experts, advisory committee members, our colleagues at the National EMSC Data Analysis Resource Center, the Health Resources and Services Administration, and, of course, others from the EIIC. So thank you all for joining today. This is just a brief overview of the talking points that we will be covering. So we want to just provide you with a brief update on the current status of PRQC, where we are with specific tasks and how we're doing there. And then we're really going to dive into implementation, and we've put together an implementation guidebook that you all can use to help you with implementing your local quality improvement efforts. As we have discussed before, September 1st is our launch date, and that means that we need to start thinking about how we're actually going to move this forward now that we've done our deep dives through all of the different intervention bundles. We'll give you all a brief discussion of data sampling, but we're going to hold most of our discussion on data sampling, data dashboards, and reporting structures for the October session. Lastly, we'll talk a little bit about environmental scans and then baseline data collection and why that's important. Crystal will finish up with just some housekeeping, and then we'll talk about what's next and leave time for any questions and answers that might arise. So hopefully that gives you a nice overview of what's to come. And at this point, I'm going to turn it over to Crystal to give you a brief update on the current status of PRQC. Crystal, we can't hear you.
All right, Kate, can you hear me now?
We got you now. Thanks.
Great. So if you keep in mind, we have been asking all of our affiliate sites to complete site visits with their training sites, and really it serves as an introductory meeting for the affiliates and the training teams to learn more about their emergency departments, the care team, and the infrastructure that exists. 11 out of our 16 teams have completed their site visits, but only 58% of the affiliates have actually completed that visit. So we are encouraging the trainers and the affiliate sites to work together to schedule that first meeting. If you see here, we've only had about 86 of our affiliates have that one-on-one meeting either virtually or in person with their training sites. So that's one thing that we're going to encourage you to complete as soon as possible for us. The next piece is the Site Visit 1 survey, and really the purpose of this was to understand some of the unique and collective strengths and weaknesses of the teams. Our goal is to understand some best practices that currently exist. It's an opportunity to sort of think of potential talking points or areas for improvement for the sites that are participating. 89 of our affiliate sites have completed that survey, and so if you have not completed it, you will get a message from our team encouraging you to submit your survey as soon as possible. The next piece is a pediatric readiness assessment, and we are proud that of our 146 participating hospitals, 120 of you all have completed your baseline assessment, and that's across all 16 of our teams. That really serves as a baseline, and so we will ask, if you haven't done so already, to complete your PEDS Ready assessment, and we'll be reaching out to your trainers to ensure that we can capture that information for you. With respect to the data use agreements, 27 of our hospitals have fully executed their DUAs, and so on September 1st, those sites and their trainers will receive formal messaging from the PRQC regarding their next steps. Trainers are receiving regular updates from NEDARC regarding the status and where any barriers currently exist with getting those agreements signed. But if you know that you're having trouble getting your DUA signed by hospital leadership, be it an issue related to whether the collaborative is based on research or quality improvement, whether there are questions regarding the confidentiality of data, if there are any questions about the use of data, we encourage you to reach out to your trainer or a member of the NEDARC team, and we will hope to sort of facilitate that process to ensure that your team is ready to start. And so now what we're going to do is switch gears and start talking about the implementation framework. Kate, you're still here?
Yeah, great. So hopefully everyone can hear me. And just real fast before we jump into the implementation guidebook, I just wanted to mention a couple other things. One is that if you have not completed the pediatric readiness assessment, for all of you on the call to know, the portal will actually be closing in the next few months. And the reason for that is that NEDARC will be preparing for another national assessment of pediatric readiness at some point in late 2019. And so if you have not completed your pediatric readiness assessment, if you're one of the few, please do so now because that opportunity will be lost. The second piece I just wanted to mention briefly is, with respect to the site visits that Crystal mentioned, please know these, again, are not any kind of verification visit. The goal of these is to get to know each other so that you can help support each other better. The more that the trainer knows about your site and that you as champions know about the trainer, the better you all will be able to work together and identify potential change strategies that might be most effective. I think it also creates this collaborative spirit that we talk about a lot, which is about being able to work together and the transparency, and that's really how we make those bigger leaps forward. So at this point, as Crystal mentioned, jumping into the implementation framework. So what we have done is crafted an implementation guidebook because if you're going to start quality improvement efforts, particularly as we are in this collaborative, it helps to have a little bit more information and a structure for being able to be most successful. And so this guidebook provides a number of resources to you to help support you as you begin down this path. What you'll see here on this slide are just the bullets of different sections of this guidebook. So we are not going to be discussing the first few of these, so overview of the collaborative, common terms, and participant expectations. We've already covered those in full with all of you in the earlier parts of this collaborative, and hopefully you feel very well versed in all of those terms and the background that's supporting this project. But know that that is available to you if you need to review any particular content. It also describes some important dates. And then you'll see key 1, 2, 3, and 4 are specifics that we're actually going to get into today to how to make sure that your efforts and the work that you put in actually results in improvement. The last sections of this guidebook include a list of members and who all is part of the collaborative, both at the EIC and NEDARC, but also hospital member participants and team participants. Finally, there are a number of appendices that are also included here, and those include some examples of quality improvement concepts like key driver diagrams and SMART aims and process maps, as well as some talking points related to the work that we're doing in this collaborative, and then some information on the QI education through IHI and the MOC process. So this is available to all of you to be used to really walk you through the next steps, and hopefully you find this helpful. So what you'll see on the next slide is just kind of a snapshot of the various steps that it takes to really be successful in implementing quality improvement processes. And you'll see that we've kind of broken this down into 5 key phases. So the first being really understanding the framework that exists within your hospital, understanding the background of the collaborative and the barriers or enablers to the work that maybe is currently being done or that might be done at your hospital. Then really understanding how your hospital works and the current processes that are in place, gaps that exist, and the like, and we'll talk more about that. Really beginning to garner support or engagement from an internal team, and then working through an actual implementation plan with a timeline for implementing certain aspects, and then making sure that you can sustain that and communicate progress back to those core teams. So this is kind of what we're going to be talking about today in a little bit more depth. And at this point, I'm going to turn it over to Diana to start talking about Key 1 of the implementation guidebook.
Good morning and good afternoon, everyone. We're glad you're here with us, and it's a very exciting time as we move forward with implementation. On Key 1, build a team, it's important to understand and keep in mind that the achievements of an organization are the results of the combined efforts of every individual. I think it's also important for us to remember that we can each do good things by ourselves to improve the care of children, but together, though, we can do great things. So the importance of a team is highly critical. Next slide, please. So part of our job with Key 1 is to build a bridge or to build a team, and part of the responsibility here is identifying the right team members. How do you identify who needs to be on your team, and building in a support system to help you with the implementation. And as these individuals help you with implementation, they should be driving success as you move forward with each of the intervention bundles. Next slide, please. As some of you may be familiar with this particular grid, our actual cube, and what this cube depicts here is a methodology for helping you identify team members to support your efforts. If you look at the vertical line here, you'll see that this particular piece looks at the power of the individuals that you're recruiting. Can they actually help you implement change? We've all been on teams where we have high interest, and yet we really are not given the power to implement the change that's to occur. Then if you look at the horizontal line there, you'll see that this is directly related to the level of interest that individuals have, or the passion to make the change occur to improve the care of children. So it's important that as we look at our members, that we look at specifically, are they high-powered? Are they going to be able to help us? Or no, they really don't have any power, but they really have high interest, and therefore they need to be kept informed. And because just by being informed, they can lend support to you and your team. Can we have the next slide, please? We're going to be using that grid as we talk about intervention specifics, but what I'd like to review very briefly with you at this point in time is this particular boxes show what a core champion team, what you need to think about having on your internal teams. This would be at each of the facilities. You already have a pediatric champion. The pediatric champions are many of those who are on the call today, and we're glad we've got you. You're going to be the leaders of your team. Who are some of the essential stakeholders that you need to consider having on there? Well, obviously, you need to have representation from your emergency department care team. This would include both physicians, advanced practice providers, charge nurses, technicians, and we didn't put it down there, but as we get into interfacility transport, obviously the unit secretary would be an important person to have as part of your team as you talk about preparing to copy medical records. ED leadership is going to be critical. It's nice to have a lot of passionate staff folks involved, but if the leadership's not there to provide support to you as well, that those changes and that passion will never become reality. An executive sponsor, this is the person, every facility that joined the collaborative had to have someone at the very top signing on. And this person, we consider them to be an executive sponsor. It's the C-suite individual, and we're going to talk about them a little bit more under considerations. So your local PRQC improvement team, some other individuals that you may want to consider making part of your team as you move forward, including more of your staff. Sometimes it's nice to just open it up to anyone who would like to participate, but if there's specific individuals that you can't have on there on a regular basis, but you need them to be there to support your efforts, reaching out to them to see if you can potentially incorporate them via telephone conference call, webinar. There's other ways to include them. Quality improvement specialists. Every hospital has to be working on quality improvement. Many of them have quality improvement offices, and reaching out to that office and requesting someone from that office to work with you would be a big plus, because that's going to help you, but it will also help them as they have to report to some of the regulatory agencies regarding their quality improvement work. Sometimes risk management, they have another office, and they may also lend support to your initiatives. Nurse educators. Many emergency departments today have a specific educator for their emergency department. That person is going to be very helpful as you begin to tell the story of Peds Ready and the different initiatives. So it's important to have that person. If you don't have your own ED educator, I would suggest that you reach out to the nursing office to see if one of the educators who works with the hospital in general could help you as you move forward with your initiatives. Data support, our electronic medical record specialists. It would be important potentially to have someone who works in either or both of those areas if available to you, because there is data collection involved with this collaborative. Many hospitals also have joint practice teams, and if you do, you may want to reach out specifically to one of those joint practice teams if, in fact, to elicit additional support. Some of the considerations that you need to think about when we talked about the executive sponsor and some of the other team members who have high passion but can't attend all of your meetings, they don't need to attend all of your meetings to be supportive and to lend credence to your efforts. But they will need to have regular communications as to what's going on. And they will be helpful in final decision-making, needless to say. And then the individual that you reach out to, keep in mind that they should be familiar with your hospital's medical record, the generation of electronic reports, because they're going to need to understand how you're getting your reports together. They're going to need to understand data abstraction and data entry. And this role may be filled and probably will be filled by many of the PRQC champions, but many of our champions from some of the affiliates have begun to reach out to identify a second individual to help co-lead and to help collect this information. If you are a larger institution where research is going on, you may find that a research assistant may be of help. Next slide, please. So let's talk about building intervention teams. By this time, many of you have your PEDS Ready data. You've begun to look at processes within your hospital, and you'll get more into specifics when we talk about doing that environmental scan. But who are some of the folks you need to consider for each of the intervention teams? For weighing children in kilograms and identifying abnormal vital signs and escalating care, which are bundles 1 and 2, you may want to consider including a pharmacy staff member because they are the ones who frequently become aware of orders that are not appropriately geared for kids, especially if kids are being weighed in pounds as opposed to kilograms. Your triage staff are going to be critical. They will help you with both weighing kids appropriately as well as discussing some of the nuances around abnormal vital signs and how do you move care forward with that. Biomedical engineering, most of the hospitals have someone in that capacity. If you've got scales that weigh both in pounds and kilos, they will be helpful in coming up with a process to lock the scales and keep them locked so that children truly can be weighed in kilograms. EMR representative, we talked about them already, pulling them in to help with filtering and being able to pull out some of the data you will need for these in this particular bundles. And then a patient family representative. Those of us who are familiar with the research world and many of the things that are going on in the larger institutions have come to realize that grant funding is kind of limited unless you have a consumer involved with looking at your study and how this is going to directly impact the care that they or their family member is going to receive. So having them on board as part of your intervention team, identifying a representative helps understand where they're coming from and what their specific needs are going to be. And this is going to be especially important when parents are used to being told that their child weighs 15 pounds, 7 pounds, 3 ounces, and we're suddenly converting over to kilograms. What is it that we can do to help them better understand why we're doing it and what needs to be covered in that communication is going to be extremely important. Next slide, please. So let's move on and talk about Bundle 3, our interfacility transfer. This one is going to be a little bit different because not only are the representatives that you're going to want on your team internal, but we would strongly encourage, because of some of the data that's going to be collected with this particular measure, that you pull in some representatives from outside your facility. So you need representatives from your nursing and your physician staff. Their input's going to be important to talk about interfacility transfer processes as they perceive them. A representative from the local EMS agency, because frequently EMS is called in to help with transfer of patients to another institution. Many hospitals have a transfer center. If you don't have one, that's not a big deal. Transfer centers frequently help coordinate the transfer from the sending facility to the receiving center. We're also going to recommend that you reach out. Where do your patients typically go to receive care? And you all know where they go. And reaching out to those particular facilities and asking them to have a representative either meet in person or meet via conference call with your planning calls, and that would be very important. If you're a trauma center, regardless of level, it probably would be nice to have the trauma team coordinator or a representative from trauma services participate in interfacility transfer, because you're not a pediatric trauma center and you've got a severely injured child, or you a child who's injured and you don't have the subspecialists available, you're going to be transferring that child. And that so many injured children are moved onward to additional resources, and as a result, having the trauma team coordinator or manager or someone from that team on board with you will be very helpful. ED clerical support, having that person come on board to figure out how you can more quickly and more easily get medical records copies and ready for transfer. Telehealth, if you have a telehealth program, probably need to be called in as well, because they may be the first reach out to the receiving center where you would be transferring a child, so that the receiving center can actually see what's going on and help you in initial care of that child and packaging that child for transport. Transport services, many children are transported utilizing a pediatric transport service from the receiving center. If, in fact, that's the situation, this would be another person who could certainly strengthen your team and make sure that interfacility transfer bundle is successful as you move forward. And again, no individual is more impacted than the patient and his family when transfer becomes necessary. Patients and families typically go to the closest ED. They know those folks frequently. They're comfortable in that environment. When it comes time to transfer, suddenly their level of comfort is diminished, and there are things that we as healthcare providers can do to help decrease their anxieties and help them feel more comfortable that the decision to move the patient onward was truly something that needed to happen. Next slide, please. Okay. Now we're going to talk about Bundle 4 and the team. This is a very different bundle, as you've learned over the last several weeks, because we frequently don't have disasters that we can rely on to implement our plan. Therefore, we need to do disaster drills. So some of the folks that you should consider pulling in specifically to help you make improvements with this intervention bundle and make sure the needs of children are incorporated into your hospital disaster plan include the emergency preparedness coordinator. Every hospital has one, so you need to identify who that person is and see if they are a representative from the disaster committee who works closely with them can join you to make sure that this intervention bundle becomes successful. Again, patient family services. Families will again be impacted, and having them involved on the ground floor to help you integrate the needs of kids and families into your disaster plan will be very helpful. They become very strong advocates, we've learned over the years. Emergency Preparedness Committee representatives from core clinical areas. You will see that there's many examples listed there, and I would strongly encourage that you try and get as many of those core clinical areas included on your committee or your team, only because every one of these services will be impacting the disaster needs of children. Okay, can we go to the next slide, please? Okay.
And yeah, Kate, I'll go ahead and jump in with the next phase. So Key 2 is focused really on obtaining or garnering stakeholder support. So Diana just went through the entire stakeholder grid and demonstrated how useful that can be at identifying core individuals to serve on your internal site-specific team. And that's not to be confused with the teams that we've created within the PRQC that are regional teams composed of trainers and affiliates. So I just want to be clear that when she's talking about building a team, we're really talking about your internal site-specific team. The stakeholder grids can also be used to help identify stakeholders that might not actually serve on the team, but they might play a role or they might have some kind of investment in the work that you're doing or interest in the work that you're doing. And so when we talk about the next phase, we're talking about not just how you get your team together and think about timeline and objectives and change strategies and the like, but also how you communicate back to the larger institution or other stakeholders about the work that you're doing. And so obviously in order to do that, you need to have some specific talking points that you can utilize. We would encourage you all to think about using some of these important resources that are listed here, like the National Pediatric Readiness Assessment data, certainly any specific gaps that you might identify through the environmental scan, as well as some talking points that we've pulled together and that you'll see as part of the appendix for this guidebook. And so just to use one of our, collaborative timelines, which is that we're on a mission, but when it comes to stakeholders, we really need to stay out of the weeds. They do not need to know all of the specifics about everything that we're doing. That's what our internal teams are for, to really talk about enablers and barriers and the like. But what they do want to know is what we're working on, what gaps we've identified, and what goals we have in terms of making a change or making a difference. And so those are some of the things that you want to be thinking about when it comes to this phase. If we go to the next slide, another thing that can be helpful when you're talking with some of these external stakeholders is the potential incentives associated with the work that's being done. We're going to be talking a little bit more later today about the maintenance of certification credit, but certainly any physicians that are participating in this work from your site will be eligible to receive MOC credit. There's also, of course, the continuing medical education credit that is being offered through these learning sessions and the like. When it comes to nursing, maybe related to clinical ladder projects or magnet recognition, ENA's Pediatric Readiness Award, which we know now exists, which is wonderful, and the ENA Lantern Awards. As we mentioned in the application, we know that for all of those sites that are participating, they will be receiving a letter essentially of commendation, just thanking the site for their participation and efforts to improve pediatric emergency care from the Health Resources and Services Administration. There's also the need through the Joint Commission when it comes to accreditation to be able to demonstrate that there are active ongoing quality improvement efforts, and certainly the work of this project could be used as a demonstration of that effort for Joint Commission requirements. Of course, there's opportunities for benchmarking against similar sites, whether that be sites that are similar in geography or hospital type or ED volume. But that can be really helpful, especially for hospital administrators and communities to hear about. We'll also have the opportunity to be able to share and adopt best practices. So that's very helpful. As many of you may be aware of, the American College of Surgeons Committee on Trauma has just integrated pediatric readiness into their criteria for trauma center verification. And so this, of course, helps to meet those needs. And lastly, just really being, a pillar or safety net for the community is how can you use this project to help support community support or help garner community support and awareness of the work that's being done. So in terms of just some special considerations, as Diana mentioned, it may be very helpful to have C-suite sponsors who signed the application, letters of commitment and or ED leadership participating on the team. But if not, if they're not actually part of the team, at least to keep them engaged in the efforts and the progress that are being made. And then secondly, making sure that we're garnering support from the ED care team as well. So obviously we're implementing quality improvement efforts within the emergency department. We want to make sure that the entire emergency department care team is aware of the work that's being done, the timeline and mobilization, and the purpose of these efforts. So just making sure that you can provide that communication to them. So at this point, I'm going to turn it back to Diana to speak a little bit more on communication.
So with communication, we know that developing a comprehensive communication plan is essential for each of our pediatric champions who are leading a quality improvement effort. The pediatric champion must be able to share knowledge and ideas and to transmit a sense of urgency while being enthusiastic with the members of their team. Can we have the next slide, please? So the communication process, if we look at this just briefly, and then we'll get into some of the weeds related to it. Identify the purpose of your communication. Why are you communicating with your team members or others about this project? Identify who your audience is, because your audience will frequently dictate the types of information that you are sharing. Plan and design your message so that it's effective. Consider your resources. What resources are already available to you as you continue to develop your message. Strategize how you'll connect with the audience and spread your message, and then the importance of follow-up messages. Next slide, please. When we talk about identifying the purpose of your communication, as you begin building your team, you're trying to seek buy-in and participation for both your core team and the implementation folks who are going to be helping you with the change strategies. You'll need to formally introduce the PRQC to your ED staff and make sure that you're using talking points that tell the pediatric readiness story. As I mentioned earlier, children are frequently taken to their nearest community ED, and therefore, even though you may not treat a whole large number of children at your facility, the reality of it is because those children and family come to your EDs, it's critical that you be PEDS ready as well. You need to report progress to your stakeholders on a regular basis. They already have an interest in what it is that you're doing for our patient safety. They want to make sure that the ED flow is smooth and as easy moving as possible. And they want to ensure that your patients and families have a greater satisfaction. So the purpose of your communication, these elements need to be considered as you're moving forward. Next slide, please. Identify your audience. Your audience is C-suite or hospital leadership. They don't want to know the weeds of how you're implementing things. They frequently want to know how it's going to impact the bottom line or how it potentially can impact the community's assessment of your facility, and those are the types of information that need to be shared. A hospital network, if you are part of a network, and we know many of the affiliates that are participating in this initiative are parts of networks, then this provides an opportunity for you to communicate to other facilities who are not participating in the PRQC how you all are working to improve pediatric readiness at your facility. It's also an opportunity to share information, again, with the community, especially if you have a public relations office. The only thing I would caution you about is if, in fact, you want to share information with the hospital network or the community through your public relations office, it's going to be critical that you make sure that your C-suite and hospital leadership know that you would like to share this information and that they provide the support for this as well. It's going to be important that your emergency department care team is one of your audiences so that you can regularly communicate with them the progress, the change strategies you're working on. And many of the states, our teams at this point in time, have the Emergency Medical Services for Children manager for their state involved in the team, and they're going to want to know how things are going as well. So please keep them as one of your audiences as you share your plans. Can we go on to plan and designing your message? And we'll talk briefly about those. Next slide. Okay. Make sure that you always have a 5-minute elevator pitch ready about pediatric readiness and the intervention bundle that you are working on, because you'll frequently only have 5 minutes to share that information. If you can provide a facility-specific fact sheet utilizing some of the resources that Kate talked about already, so that you can have that available to provide to other folks that could be of great help. And as we mentioned earlier, we do have an introductory slide deck that will be available for you all to utilize and to adapt them to make them facility specific for presentation purposes. But again, make sure that you're tailoring your messaging to the audience that you are speaking with. Next slide, please. We'll talk about considering resources. Kate mentioned some of these. PRQC talking points, basic facts, those are available. The slide decks and recordings for each intervention bundle are also available in box at this point in time, and Crystal will have some additional information to share soon. Your hospital's pediatric readiness assessment data. This is a critical piece because this is an assessment that was done by you or one of your staff colleagues, and it clearly will show where the gaps are and provides validity to your efforts. And then the PRQC dashboard, you're going to learn more about the dashboards coming up in the near future, and this will provide information for you to share with administrators and with the additional audiences that you work with. Next slide, please. We'll talk about considering strategies on how to connect with your audience and spread your messaging. Newsletters, if you want to develop a newsletter that goes out periodically, just telling what change strategy you're working on and what your data is beginning to show would be helpful. Listservs, having an email listserv of every member in your ED may provide an opportunity for you to communicate. Monthly team meetings, bulletin board, making a little bulletin board display with your data, and again, addressing specific change strategies could be helpful. Hospital quality and safety meetings, taking your information to those meetings could also be of help. Next slide, please.
I'm getting a question, Kate. We're getting a little feedback. Kate, are Diana on speakerphone?
I'm not. I am on my phone speaker. I can turn off speaker, but my computer's off. Normally somebody's computer sounds on. Yeah, I just turned off.
Okay, give me 1 second while we address it. Sorry, everyone. Give us 1 second. All right, Diana, so you are the only one that's unmuted at this time besides myself. Go ahead and finish with your slide.
Okay. And as we mentioned on the last point here, if you have a hospital quality improvement committee, which you probably do, and are a safety committee, make sure that you're taking your information back to those committees to share as well. Can we go to, I think this is the last slide that I have for this particular section, follow-up. Make sure that all of your data results are being shared with your key stakeholders as well as your team members, and make sure that you integrate the feedback into next steps, whether it's the selection of the next change strategy or passing the information along as a best practice identified by nurses and physicians on a particular shift as well. And I think go to the next slide. I think I'm ready to turn this over, if I'm not mistaken. Yep, this goes back to Kate now. Thank you.
Okay, Kate.
All right, can everybody hear me?
Yes.
Great. So this last phase that you'll see in the implementation guidebook is really about the strategic planning and how we move it forward. We just talked about assessing assembling the local QI teams, but with that team, we now need to talk about what bundle we're going to work on, what change strategies we're going to adopt, how we develop an action plan and a timeline for actually making those changes, and then how we go about assessing performance. So to use our collaborative tagline, moving it forward. When it comes to strategic planning, it obviously has a number of phases to it. Most of these we've just discussed, which is any foundational tasks or work, knowing your hospital's framework and researching gaps and creating a team and getting agreement on that. But the last two phases are actually developing the implementation plan and then discussing sustainability. We'll be talking about sustainability towards the end of this collaborative, just making sure that everybody is prepared even after the collaborative ends to keep it going. But what we wanted to highlight at this time is just the very specifics of developing that implementation plan and what you might discuss specifically with your internal team. So if you go to the next slide, really this should begin with developing your own SMART aim. We've talked about developing SMART aims for the collaborative and what our global aim is, but we want each of you as an individual site to think about what your specific, measurable, actionable, timely aim is actually going to be for your site. And we'll talk about some examples for that, but what are your goals, and make sure that those fit the needs and the support of your stakeholders. The second will be, of course, identifying, okay, what steps are we going to take? And it might help to have a process map that you actually use to work through. So a process map is really just a way of walking through a process that exists in the ED. So, for example, when it comes to triaging patients, there's a process that occurs from when that patient arrives to the emergency department, how they move into the triage room, how triage is actually done, and then how any kind of notification is made. And so that's really walking through a process map, because using that can help you identify which change strategies might be most effective or where you might have the greatest impact. Then next is really mapping out a timeline. So on such and such a date, we'll actually go ahead and roll out staff education or knowledge reinforcement, such as placing posters in the triage bay and things like that. So really mapping out exactly how you're going to do it, when you're going to do it, and knowing that everyone's in agreement so that you can communicate back on that. Making sure that you have the resources, tools, and or education developed to actually move forward with that. So if it is posters, then making sure those are ready. If it's education, making sure you have a timeline for providing that education or modality for doing it. Making sure you garner that support before you actually go through the implementation, and then beginning to think about the chart selection process. So we talked about building that internal team, and we would recommend that you consider scheduling some standing meetings or forms of communication with that core internal team about the implementation that you're planning, and be able to move forward with that. So if you go to the next slide. These are some QI concepts, and I think Crystal's going to walk you through some of these elements of SMART aims and key drivers.
Thanks, Kate. So your guidebook will have an appendix section with a couple of examples of some QI tools that we will ask that you integrate into your improvement work. It will also have worksheets that you can adapt for your site and share with your team. So one of the examples will be developing a SMART aim. This is going to be sort of the foundation or hallmark of the work that you're doing. And so we're going to give you examples of that. So let's think about the second bundle, which is abnormal vital signs. So step one is really reviewing the PRQC global aim for this intervention. Step two will be developing your specific aim for your site, and then developing a specific aim for the initial PDSA cycles. So when you think about the first step, it's the PRQC global aim. And so for that particular bundle, the collaborative has decided that we will work collectively by December 2019 that for 100% of those pediatric patients with abnormal vital signs, will be identified by the healthcare providers in the emergency department. So as a collaborative, all of those sites that are participating in this particular bundle will specifically be working to have 100% of their patients identified. The next step would be that the site should identify a long-term goal. So each individual hospital that's working on this bundle will have their own AIM statement, and that could be that by December 2019, 100% of those patients will have a full set of vital signs collected during triage. So that's the long-term goal. But what we're going to ask you to also do is come up with a PDSA-specific AIM statement. And so let's say you are starting your improvement work in October. The AIM statement could be that by March of 2019, 100% of the pediatric patients will have their blood pressure collected during the triage. So this is how you're really operationalizing this, is that your first area of focus is on blood pressure. And then over time, you're going to progress to capturing the full set of vital signs by your 2019 target date. So this will be one of your very initial steps when you are developing your project implementation plan, and so we'll have some resources available for you to assist with that process. The next piece is a key driver diagram. So you're going to keep in mind that during our deep dives, we discussed primary drivers and a series of change strategies. Those change strategies were somewhat of an exhaustive list. We're not saying that every hospital should try to adopt all of those, but as a team, your core team, what you're going to do is identify what's most meaningful and what will sort of give your hospital a quick win at the beginning to show proof of concept that you can pull together the resources to work towards your AIM statement. So here's an example of a key driver diagram. As we mentioned during the deep dives, it's something to help you visualize your process. And so rather than arbitrarily identifying change strategies, this is what you're saying, is that for this initial PDSA cycle, and we're going to use Intervention Bundle 1 as an example, which is weight in kilos, that by June 2019, 100% of the patients less than 15 years of age will have their weight measured in kilograms. And so to do that, we're going to focus on your hospital will focus on 4 drivers that will be related to your guideline statement, infrastructure changes, some education, and then patient-family engagement. You'll notice that our sort of intervention bundle has a series of drivers, but your hospital may decide to really focus on 1 or 2 of those. And then here you'll see the change strategy. So this is the actual improvement work that your team will roll out over the course of several PDSA cycles. So for the guideline statement, it could be that your hospital decides to refine the existing guideline and include pediatric patients. One of the infrastructure changes that you may decide to roll out for a particular PDSA cycle could be that you're only going to use a scale that's locked in kilogram mode for that PDSA cycle. Education, it could be that you decide to pull some slides that give some brief overview of PRQC and what your plans are for the next month and a half working on this improvement effort, and share them with the care team. And then lastly, patient-family engagement could be that you decide to develop and implement a script for your triage nurses related to this bundle. This could be a central document that you use at your meetings before you show the data to say, for the next sort of couple of months, this is what our AIM statement, these will be our interventions, and now let's show you what the data suggests. Keep in mind that you will be capturing baseline data, and we'll talk to you a little bit more about that in the coming slides, but you'll have baseline data to show what your trends have been over a certain period of time, and then once you incorporate those change strategies, the PRQC will be providing you with site-specific data so that you'll see how you're progressing towards your AIM. And so what we'll do is capture the last sort of steps that will be coming sort of towards the spring and summer of 2019. And so the next step will be to take a leap. And what you'll be keeping in mind are some of the key questions that you'll have to ask yourself is how close is the team toward achieving their AIM? What can we do to push our ED to the next level? What are the opportunities to sustain some of those improvements that we made? And then in summer 2019, what we're going to do is ask you to reassess your readiness, identify new goals, consider additional PDSA cycles. You may need to modify your SMART AIM based on your progress over a couple of months, and then choose other intervention bundles that you like to pursue. So let's say you've been working on disaster planning for the last 6 months and your care team wants to do something day-to-day for their patient population, they may decide to start focusing on weight and kilos. So we're going to really ask teams to stretch their improvement work come summer of next year. And then the final phase of the collaborative will be keep on trucking. So this is the time that you're going to be sharing your performance and your data with your teams, focusing on those small steps forward, looking at ways that you can sustain your improvement efforts. It doesn't help just to do the improvement work, but you should be disseminating those best practices. So it could be that you're moving from outside of the ED into inpatient units with some of these intervention bundles. It's going to be important to spread the word on your performance and your progress and then share the value of that QI work really to ensure that you get ongoing support from your hospital. So now what I'm going to do is pass it back to my colleagues to start discussing monitoring and measuring your success.
Great. Thank you, Crystal. So we really just wanted to focus in on three core elements that we've talked about: environmental scans, data sampling, and baseline data. Really, as we all begin to launch our efforts starting on September 1st, what we'll really be focusing on is the build-up, the researching, the understanding those processes. And then as we move into October, that's when we should really be thinking about getting into all things related to data. So if you'll move to the next slide, please, Crystal. When it comes to environmental scans, so this is really what helps you to determine your performance or the progress that's being made. So, of course, relative to the collaborative as a whole, we're focused on pediatric readiness, and we know that the initial assessment is helpful in terms of understanding how we do in terms of overall readiness. But when we're speaking back to stakeholder groups and especially individually at our site, we want to be able to identify specific gaps that exist so that we can really speak to the work that's being done. And that's where these environmental scans are really helpful, is that through targeted questioning that's focused on the specific elements of an intervention bundle, it's a way for each of you as the champions to walk through your current processes and identify gaps that exist so that you can determine what might be the most helpful change strategies. You also might find that these environmental scans really help you in the decision-making process, because as you work through these, you might realize that there are gaps that exist relative to a bundle that you thought might have already been working seamlessly. So this might be a way to help you be more successful and or more impactful in terms of the work and the efforts that you're doing. These environmental scans will be sent out at the end of this week by August 31st so that you can effectively begin to move into this work beginning in September. There will be some targeted questioning, as I mentioned. It'll all be through REDCap, which is a really nice, simple system so that you can see exactly how you're doing and get your own information back. And then it also is going to be all in one unified single environmental scan. And so the benefit of this is that we know many sites have already stated that they plan to work on maybe 1 or 2 or 3 bundles throughout the course of this collaborative. And so this allows you to really identify those up front and figure out what those gaps might be and how you might move forward. The second piece that we wanted to mention is related to data sampling, and we really just wanted to provide an overview at this point just to really get you thinking about how you're going to be looking at data for your particular site. So if we're considering potential consequences of an individual change strategy that we choose, then we really do need to consider the potential risk that might exist to patients or providers or the organization as a whole. And so really the question is, are there any potential risks of the improvement efforts that we're going to be implementing? And I think, you know, relative to the work that we're doing, the risks in general are quite low, but we know that people will resist change if our early efforts don't work. And so we have to be very cognizant of the work that we do early on to garner support and buy-in as we move forward. The work that we're doing related to bundles 1 through 3 in particular have a direct impact on patients. And so it's really important that we decrease any potential risk and perhaps even more importantly, that we decrease any potential extra work or processes that would create extra work for staff, especially if they don't actually result in improvement, because that is a way that we might lose support up front. And so the discussion that we just had on team building and stakeholder engagement is all really important in ensuring staff or care team, physician readiness to actually make the changes that we're going to be talking about. So for the most part, I think that we will be working with the lowest row here. So we have a fairly high confidence that any change that we're going to make is going to lead to at least some degree of improvement. We know that the changes that we're making are not expensive tests. We're not talking about high-end resources. And so the cost of failure is relatively small. But really the other piece of this is what's the level of readiness among our care team? Do we need to start with a small-scale test, or can we move to a more large-scale test, or can we just move forward and go ahead and implement these change strategies because we know our teams are ready to do this? Remember that when we're talking about the work we're doing here, we're talking about quality improvement work. We're not talking about implementing a research project. So we're not looking to collect hundreds of charts to create, some kind of regression models or t-tests to look for significance and change. What we're looking for is much more simply trends. And we'll be talking a lot more about run charts in some of the future learning sessions, but what we're looking for is just trends in improvement in care overall. Because this is what we're going to be doing and what we're working towards, we do want to at least get some kind of baseline to know that we are making a difference. And as we've discussed before, our recommendation is that we try to gather, if possible, 30 charts, patient charts, so that we can see or really get a true sense of our current performance. As we move forward with PDSA cycles, we might be looking at maybe 6 to 10 charts a week. That would be sufficient. And again, it's going to depend on your site and the volume of patients you have and the level of readiness among your ED care team to begin looking at these charts. If you choose a bundle like InterFacilility Transfers, then most of the charts that you're going to be reviewing should be patients that are actually transferred out. So keeping that in mind with respect to your pediatric ED volume is that you may have longer periods of time between change strategies just because the number of patients that you can actually assess becomes smaller. And so we know as we move between bundles 1, 2, and 3 that the number of patients that might have, for example, abnormal vital signs is a little bit less than those that are being weighed, and those that are being transferred is less than those that have abnormal vital signs. So just keeping that in mind as you begin to think about how you're going to sample your own data moving forward. But our recommendation is that we aim for approximately 20 to 30 charts per PDSA cycle because we anticipate that we'll have small to moderate improvements relative to the normal variation, and that's where that puts us for QI recommendations. So Crystal, if you'll go to the next slide. The last thing that we wanted to mention is just the baseline data collection. And of course, I just talked about this, that this is really important because it's going to help you identify your current performance prior to implementing any intervention bundles. And this is what is going to give you the talking points. This is what is going to give you the support at your site and among stakeholders that might not even be internal to your team. It helps you to measure the impact of the efforts that you're putting in. The one thing that we want to mention is that it's really important that you do your baseline data collection prior to implementing any change strategies. So one of the change strategies that Crystal mentioned in the key driver is potentially educating staff on the importance of pediatric readiness or weighing children in kilos. And just that education alone can be impactful in changing the way that a process is done. So just be attentive to that, be aware of that, because we're trying to avoid any potential Hawthorne effect. The other important piece to know is that when we're talking about baseline data collection, we really recommend that we start with just random sampling. We're not talking about stratification. So in other words, we're not trying to look at performance for an individual provider or performance on Saturday versus, Friday, or performance at night versus a day. So those are examples of stratification. What we're trying to look at is just random sampling so that you get an overall assessment of performance across the board. And so just as we begin to move into the actual launching of this work, begin thinking about how you might create a standard data collection process that works for you at your site based on the readiness of the ED Care team, based on the efforts that you plan to implement, and the potential risks if they exist, and the volume that you have at your institution. So at this point, I'm going to turn the floor back over to Crystal to talk a little bit about some housekeeping.
Thanks, Kate. So if you keep in mind, we mentioned that September 1 is our go-live date to start really moving forward with implementation in our intervention bundles. And so the month of September, all sites should be working to finalize their data use agreements if they have not established those just yet. Completing the IHI modules and QI education, that will happen after we have your DUAs established. The environmental scans will also be released, and then sites definitely be convening their internal teams. And so what you can do is use your guidebook that we have provided, or that we will provide on Friday, to help you put together your core team and your implementation team. During that time, what you can do is introduce your PRQC bundles, start thinking about what change strategies you'd like to put into place, review your PEDS Ready assessment and what gaps existed there, review your environmental scans, and then formally declare which bundle you'll be participating in for the collaborative. We are asking that you identify 1 to 2 data stewards. That individual or those individuals will have access to the data portal and the dashboards that are specific to your hospital. And then we'll also ask that you review the implementation guide that will be released on Friday. For the month of October, we are hosting another learning session similar to today's session on October 2nd, but the focus will be on all things related to data. So we will discuss creating a data sampling process for your site that's based on the intervention and your hospital's engagement. We will review the data portal and our data submission process. We will review the data dashboards, how you can use them at your site and how they can benefit your collaborative efforts. The data portal will open, and we will discuss the strategies for collecting and submitting your baseline data. During that time, or in the month of October, we'll ask that you reconvene with your internal teams to finalize your next steps, and then really start thinking about how you're going to launch your first change strategy. One of the questions that we just received is, do we start reviewing charts on September 1? So what we're going to do is send out specific information with this guidebook on if you've established your DUA, your track will be very different from hospitals that have not established their DUA. But we'll have specific language on both tracks in that guidebook for you. Another piece of information is that we are currently working on a formal collaborative website. There will be 2 sections. There will be a public page and a private or protected page. The public page is being populated as we speak, and that's something that you can share with your hospital that really gives more background information about the collaborative, the members, and some basic information about the interventions and the design of the collaborative. The protected site will have much more detailed information for only our participating hospitals. It will not be open to the public. It will have copies of the intervention bundles. Everything that's posted on our file sharing site will be migrated to that protected site in the coming weeks, and you will get a password and information about logins to specifically get into that area of the site. But keep in mind, we are using our box site for the time being, and we will post that in the chat section shortly. Once you fully executed your DUAs, we will be sending information for 1 to 2 QI champions for your hospital. This will be specific to your hospital, so we won't sort of dictate which individual should have that access. It's going to be up to the pediatric champion to decide. For those sites that have established their DUA, on Friday you will get messaging about getting access to those IHI modules as well as that workbook. Keep in mind, we do have the incentive program available, so for today's session you can receive CNE and CME credit. And the link is listed in the chat box, and so just click on that survey and you'll get that information. The other incentive that is available for the PRQC members is MOC, or Maintenance of Certification Part 4 credit. We will provide detailed information about the process to all the champions and trainers, because this process is a little bit different than CNE and CME. But here's a snapshot of some of the requirements that must be fulfilled to receive that credit. So the physician must be boarded with one of the medical specialties that's under ABMS. Those physicians that are seeking credit must provide direct or consultative care to the pediatric patients that are involved in the PRQC, and they must be involved with the hospital's activities related to the collaborative for 8 continuous months of participation. They should be working with the pediatric champion or the hospital's designated PRQC champion to establish institutional readiness. So those physicians that are seeking credit should be working with you to roll out the interventions. They should be reviewing data and providing feedback. We are asking that they complete some form of QI education, because just seeing those charts is not enough, but they need to understand what are aim statements, what are change strategies, how do you understand control charts, run charts, and what's a PDSA cycle. So our collaborative will provide some resources for that QI education, and you may decide to use some pre-existing education that's happened in the past, sort of like IHI modules that they've completed at another institution, if they have had some formal education through your hospital, or they've done Intermountain Health's QI course. And then they must be attending a designated number of team meetings at their hospital, and what we're going to do is work with champions to identify what that number should be, but more details will be sent shortly. And so one question that we just received was, will MOC being offered by PRQC be enough to sort of fulfill all the requirements? So it will. We're asking for 8 months of participation, and so continuously, if they begin in September and go through December of next year, if they're boarded through the American Board of Pediatrics, a great example is that you get 25 points for each cycle that's completed. So 2 cycles of the MOC work would fulfill the Part 4 credit for them. And we will also provide you with information about how you can double dip, meaning that you can use some of the modules that currently exist to fulfill Part 2 of the credit, and then as well as completing your Part 4 requirements. So that information in detail will be provided in the guidebook. But yes, the PRQC will be able to satisfy all of your certification needs for MOC Part 4. So now what I'll do is I will pass, one more slide. It's about pulse checks and team meetings. Keep in mind that every affiliate site should be meeting with their training sites on a regular basis. These meetings will probably be virtual or over the phone, like via teleconference. If you haven't had any meetings with your training sites, please let us know and we'll reach out to them. The purpose of these meetings are to share successes, challenges, and learning from one another. It's an opportunity to get updates on team dynamics. So how are the teams evolving, any new roles or individuals that are starting a new role at the hospital, maybe as the role of the champion, and any substitutions that we need to put in place if there's a new person that's coming on board. We will be sending updates about pulse checks to our team trainers. There have been some changes with our admin team recently, so that will be some information that you'll be receiving in the coming days from our team. So now what I'd like to do is pass this back to Kate, and she's going to talk to you about the newsletter and then database access.
Great. Thank you, Crystal. So what we're trying to do, or that's in the works, is developing essentially a PRQC newsletter that would go out to all of you, just to help make sure that we have ongoing communication with you. And these newsletters would just summarize any events and discussions that have been had through these learning sessions. Included would be some information on performance and aggregate reports. We might ask for some of you to share best practices to include in this newsletter that could go out to others so that they can learn from you in the true spirit of a collaborative. And then any upcoming events, learning sessions, and the like that are down the pike. When it comes to DUA access, if you can go to the next slide, Crystal. the database access. So this is going to be included as part of the environmental scan. So as you all know, you're going to be entering data that's specific for your site, and we want to make sure that this is private, and so there will be indeed login information that needs to be generated for every individual or data steward, as we previously called it, from your site. So within the environmental scans that go out, you'll see a couple questions on your name, your email address, and your hospital name, and you'll be able to list up to 2 individuals for your site. Once we have that information, accounts will be created, and then each of you will receive an email with login information and instructions for how to reset your password and or develop a password so that you can begin to move forward with the database or the data portal. Just to note, those emails will not go out. So even if you complete your environmental scan, mid-September, those emails will not go out until the portal actually opens, because we can't have people logging in before the portal is ready. So we anticipate that those earliest emails will be sent out on or around October 2nd, which is when we have our next learning session and when that portal will open. Of note as well, we cannot release any login information until the DUA is fully completed. So we'll just have to be attentive to that, because we really don't want you submitting any data unless your site has formally submitted that DUA, just so that there's no conflict there. If you go to the next slide, Crystal. So what we have is just a list of upcoming meetings and what's next. So for your awareness, it's not a requirement, but if you have any questions, concerns, comments, if you want to ask us anything, we will be hosting our regular PRQC office hours on September 18th. Feel free to call in and join us, ask us questions. These are not structured calls. It's really just to help answer any questions you might have. On October 2nd is our next learning session. We'll be diving deep into data sampling and the dashboards and presenting those to you, walking you through that whole process. Then in November, on November 13th, we'll be beginning to look at some team updates. We'll be asking a few of our teams that are beginning to engage in the data entry and the work to provide some updates on the process and how they're doing. And then we'll also give you all some general updates on the data sampling, collection, and reporting that currently exists. We intentionally gave you all some breaks over the holidays. So for the second half of November and all of December, we will not be having any scheduled learning sessions. We will continue to host office hours as needed throughout, but will not be having any formal learning sessions during that time. Our next formal one will then be in January, and again, we'll be looking at getting some team updates, and we'll be talking about that. But this is really a key part of being in a collaborative, is really to be able to learn from each other and how things are going. We know that there's been a lot of ramping up in terms of education and deep dives and implementation and understanding the data process. But once we really get into 2019, we're going full steam ahead, and we want to make sure that folks are engaged and moving forward and don't need any additional help or support outside of what we're doing currently. We are planning on a second in-person meeting for trainers. So for those of you trainers that are on the call, if you can please note these dates, January 31st to February 1st, that will be held in Austin, similar to the last in-person session. If you can mark those dates, we will be sending out announcements soon. And again, this is for trainers only. This is so that they can provide us with additional feedback, and we can provide you all with additional support and education to help move this forward. And then in terms of other learning sessions in 2019, we'll be focusing more specifically on the application of QI methodology. That would be specific to the intervention bundles. We'll be reviewing aggregate data and the performance and progress of the collaborative as a whole. We'll also be talking about intervention-specific performance and progress. Again, no single site will ever be identified on any of these learning sessions. What we're doing is just trying to allow you an opportunity to be able to benchmark yourselves and see how you're progressing. And then finally, we will be continuing to think about team updates throughout the 2019 year so that we can hear from each other and learn from each other in that true collaborative spirit. So all the slides from today in the recording will, of course, be on the Box site as usual. And at this point, I'm going to turn it back over to Crystal, and we're happy to field any questions.
Hi, Kate. So a couple of those came in while we have been sort of going through the slides. As a reminder, we are using the same link that we always use for our file sharing site. And so what we will do is get those posted for you with today's slides and learning session. The workbook will specifically be sent out to all of the training sites so that you'll have a copy for yourself, as well as some deadlines and timelines for you to keep on your radar. For the affiliate sites, we'll be posting all the information on our file sharing site, and then you'll get messaging as well from your trainers. For anyone that's established a data use agreement, you will get a specific message from our team that talks about your next steps, so be on the lookout for that. The other piece is that specifically related to the variables, if you take a look at the intervention bundles, you'll see the list of variables that we are requesting for each of those bundles, and so we'll really go and do some sort of deeper dives into that during the October learning session, but you are not expected to be collecting any data related to the change strategies in the month of September. We are actually asking that you sort of keep it private so that you can start collecting your baseline information over the course of the next month. So just keep that in mind, but that information will be described in detail in the guidebook. Let's see. So one of the other questions, Kate, that we received.
The disaster planning question. So I see that there's a question on auditing charts for things like disaster planning seeming difficult and what type of data should be collected for that. So absolutely, the disaster bundle is really not focused on specific patients or patient charts or direct patient care, but really is focused on disaster drills and the like. You know, the first steps in the disaster planning bundle is really understanding the current processes that exist for that, and the environmental scan will help walk through that of understanding who is your emergency preparedness coordinator, who sits on that committee, is there pediatric representation, what does the disaster plan look like currently, is pediatrics called out in that, and the like. And so if you go back to the learning session that was done on July 31st that was specific to that bundle, the disaster planning bundle, you'll see some wonderful process maps that Dr. Kasny and our other subject matter experts developed to help assist in kind of those steps of working through that. The other thing that I will say that when it comes to the disaster planning intervention bundle, as we work past those structural pieces of making sure there's pediatric representation and needs represented in the plan, we'll really be looking at implementing local disaster drills, and those may be partial drills at first that just involve certain key stakeholders, but it's not expected that the champion would, initiate any massive disaster drills. But we'll be talking a little bit more about that as we move forward. Hopefully that at least helps you. We're not actually collecting patient data on that bundle, but really about the processes that exist currently for disaster planning. Are there any other questions, Crystal?
So one of the questions, if the goal is not to start collecting and entering data until October, what specifically does go live on September 1 mean?
Sure. So the go live on September 1 refers to those other pieces that we've just been talking about, which is beginning to make sure you have an internal team that's ready to go. So convening that team, researching the processes that are currently in place at your institution to identify where the gaps absolutely are. Many began this collaborative saying, oh, absolutely, we're going to work on such and such a bundle. But as you begin to really research those gaps, you may actually decide that you would rather work on a different bundle than the one that you initially set out to address. Walking through some potential change strategies, getting buy-in from stakeholders, setting up regular team meetings, and actually working on those specific change strategies that you plan to implement. So that if, for example, you decide, okay, we're going to go live with our change strategy on October 15th, then you want to make sure that you have those resources and education in place and ready to go. The other piece will be developing a plan for your data collection process, so what you choose to do at your site. So what you'll need to do is be able to go and look back at the number of patients that you see in your emergency department that are pediatric, and how you want to begin to collect those data or those charts to be able to review them to identify trends in performance. So there's a lot to do in September that we discussed. And actually, Crystal, if you'll go to, I believe it was one of the later slides, maybe slide 45 or so, that looks at all the work to do in September specifically. There you go. So this slide really outlines those steps that we need to be working on over this next few weeks.
So one of the other questions that came up throughout the call is what we'll do is send a recap of today's session with all the links that we've discussed. So you'll have a link to the file sharing site, a link for CNE, CME credit, as well as a link to where those intervention bundles are saved, and then also information about accessing the guidebook or the workbook for implementation. So all of that information will be sent with copies of the webinar recording and slide decks.
Any other questions, Crystal?
Not at this time.
Okay, great. Well, we know this was an awful lot of information that we covered today. Hopefully this is helpful. We will be having office hours, as I mentioned, on September 18th, so please feel free to call into that if you have any specific questions. For those of you who have your DUAs completed, we will be sending out kind of a bulk emails with access to those IHI modules. So we were just waiting to have a few more in line. So be looking for those emails for your IHI access. And as you all begin to go through those IHI modules, you'll have a better understanding of these QI modalities that we'll be discussing throughout the collaborative. So many thanks for joining today, and we will be in touch, and we'll see you for sure on October 2nd.